Welcome to the deep dive. Today, we're really getting into the weeds on vascular trauma in the arms and legs.
Yeah, it's a critical topic, and we're grounding this discussion in, some serious medical knowledge from Rutherford's vascular surgery and endovascular
That's
therapy.
the gold standard text. So our goal here is really to understand, well, how significant these injuries are, the challenges in actually managing them.
And what really influences the outcomes for patients? I mean, life, limb function, it all hangs in the balance.
Okay, let's start with something that kind of jumped out at me. These extremity vascular injuries, they might seem like a small piece of the overall trauma pie, percentage-wise.
But they punch way above their weight, don't they?
Exactly. They account for a huge disproportionate amount of the illness, the mortality, and just the sheer resources needed.
And what's interesting right off the bat is that, arteries in the arms and legs get injured about equally often. But how they get injured and which specific arteries are hit most often, that's where you start seeing differences between the upper and lower body. It makes you think, right?
Definitely. So let's dig into the general characteristics.
Hmm.
Major vessels in the arms and legs, they make up, what, 20 to 50% of all vascular injuries? That's substantial.
It really is. And the ways these happen, the mechanisms, they vary too. You've got blunt trauma, think car crashes, falls. That's actually more common in the legs.
Right.
Then you have penetrating injuries like gunshots or stab wounds, and those happen pretty much equally in arms and legs.
So blunt trauma seems like it might bring more baggage, so to speak, more associated injuries.
That's generally true, yeah. Blunt trauma often comes with other non-vascular injuries in that same limb, and sometimes injuries elsewhere too. Suggests a bigger overall force involved.
Okay. And location matters too, you were saying.
Big time. In the arm, it's usually the forearm vessels that take the hit, regardless of whether it was blunt or penetrating.
Just the most exposed, maybe?
Could be, yeah. But the leg is a bit more specific.
How so?
Well, with blunt trauma to the leg, the popliteal artery, the one right behind the knee, that's the most common one injured.
Okay.
But if it's penetrating trauma, like a stab wound in the thigh, it's more likely to be the superficial femoral artery, the SFA.
Huh. Different vulnerabilities depending on the force type.
Exactly. And that ties into severity as well.
Right. So leg injuries from blunt trauma sound worse.
Generally, yes. Those lower extremity arterial injuries from blunt force, they tend to have higher rates of associated tissue damage, more complications, and unfortunately, higher mortality. It's likely due to the greater forces often involved and just, the larger muscle mass down there.
Okay, moving on to complications.
Yeah.
Clearly, it's not just the vessel we're worried about. These injuries often bring friends.
Unwanted friends. Definitely. Fractures are super common. With blunt trauma involving an artery, you're looking at fractures in like 80 to 100% of cases. It's huge.
Oh, and penetrating.
Still significant. Maybe 15 to 40% have a fracture too.
Right.
And the key thing is, if that fracture is open, bone breaking the skin or comminuted, shattered, basically,
Uh-huh.
that seriously increases the amputation risk when you've also got a vascular injury. The whole area is just compromised.
Makes sense. What about nerves? They run right alongside the vessels, don't they?
They do, and nerve injuries are a big deal. The data might even underreport it because long-term follow-up is tough, but estimates are around 10% nerve injury and lower extremity vascular trauma,
Okay.
but way higher in the upper extremity, maybe 40 to 50%, possibly because the nerves and arteries are packed in tighter in the arm.
So more nerve risk in the arm. Does having that nerve injury automatically mean you lose the limb?
Interestingly, no, not directly in the short term, but if that nerve doesn't recover well over time and the limb ends up being non-functional, well, that can definitely push towards a later amputation decision. Quality of life becomes the focus then.
Right. And then there's the soft tissue, the muscles and skin.
Yeah, significant damage there is common too, especially with blunt trauma. Again, seems more prevalent in the upper extremity, maybe 40 to 70% of cases.
Compared to the lower.
Around 30% maybe in the lower extremity. But what's really important clinically is that major soft tissue damage in the leg does seem to correlate with a higher chance of early amputation. You need good tissue to cover the repair.
Got it. Let's switch gears a bit to the veins. Arteries get a lot of attention, but what about venous injuries?
They happen pretty often alongside arterial injuries, actually, maybe 15 to 35% of the time. And it's likely we miss or don't report a lot of the smaller ones, especially below the knee or in the arm, because they might not cause immediate drama.
So if you injure both a major artery and a major vein, is that limb doomed?
You'd think so, right? It definitely means a more severe injury overall. But surprisingly, it's not a super reliable predictor of whether the limb can be saved or not. Yeah. And even whether you surgically repair that vein or just tie it off leg it doesn't seem to consistently change the limb's salvage outcome. Suggests there's often enough backup drainage.
Huh. What if it's just a major vein injury, no artery damage?
That's pretty rare, actually. And the good news is those isolated major vein injuries aren't linked to high amputation rates. The venous system can often cope on its own.
Okay, so back to that repair versus ligation debate for
Mhm.
veins injured alongside arteries. No clear winner.
Not really. It's still debated. We know the upper arm, distal to the armpit, and the calf have lots of extra veins. So ligating a major one there is generally considered safe unless the injury is truly massive and takes out all the outflow.
But the leg, higher up. Different story?
Potentially, yeah. There's a theoretical worry that ligating a big leg vein could cause venous hypertension downstream, maybe compartment syndrome acutely, or chronic swelling later.
Theoretical, you say.
Yeah, it hasn't been consistently proven out in studies, and it's worth noting that fasciotomies, those pressure-releasing incisions, are often done in injured legs with vein injuries anyway, kind of acting as a safety net regardless of how the vein itself is managed.
Okay. What about swelling edema after dealing with these vein injuries?
Swelling is definitely expected if you ligate a major vein in the lower leg, especially at the popliteal level behind the knee. It happens quite often, but usually gets better over time as collaterals develop. Repairing the vein might cut that temporary swelling roughly in half.
And in the arm.
Significant long-term swelling is much less common after ligating arm veins, probably because there's just a better network of backup veins.
And you mentioned blood clots earlier. VTE risk.
Yes, a big concern. Extremity vein injuries carry a pretty high risk of VTE, DVT, or PE, maybe 30 to 50%.
Wow.
But interestingly, that risk doesn't seem clearly tied to whether you repaired or ligated the vein. Some studies even hint at higher VTE rates after repair, maybe from the trauma of the surgery itself.
It's complex. What about actually trying to reconstruct a badly damaged vein?
Venous reconstruction is technically tough. It's really only something you'd consider in a stable patient where the venous outflow is severely compromised. Think maybe helping prevent an arterial repair or shunt from clotting off early.
Where would you most likely consider it?
Probably in really severe mangled limbs with vein damage at the axillary level or the groin or behind the knee.
And how well do those repairs do?
Short term, keeping the vein open, maybe around 70% patency for femoral and popliteal repairs. Longer term data is sketchier. Below the knee vein repairs generally don't do well. Simpler repairs, like just sewing up a tear, tend to do better initially than complex grafts.
Okay, stepping back to the big picture outcomes. What are the absolute priorities?
Priority 1, stop life-threatening bleeding. Priority 2, prevent early limb loss. Then, looking down the road, you're worried about late amputation and how well the limb actually functions. So it's hemorrhage control first, then reperfusion to save the limb and hopefully keep it working.
Those first minutes and hours sound absolutely critical. What about the really long-term picture? How do these patients do years later?
That's where our data gets a bit thin, unfortunately. A lot of studies on civilian trauma only follow patients during the hospital stay or maybe for less than a year.
So we don't have great info
On how well these repairs hold up long-term or detailed info on functional ability, quality of life years down the line. It makes it hard to grasp the full lifelong impact.
Let's talk mortality. How often does someone actually bleed to death from an arm or leg vascular injury?
Thankfully, it's relatively rare, maybe around 2% of cases. When it does happen, it's usually from penetrating injuries.
And location matters again.
Yeah, injuries higher up in the leg to those bigger proximal vessels are the most likely culprits for exsanguination. The risk generally drops as you go further down the limb.
And things like tourniquets are making a difference.
Seems like it. Most deaths happen before the hospital, right? So the wider use of tourniquets and EMS borrowed from the military is likely saving lives.
But not foolproof.
No, especially for those junctional injuries, armpit, groin, where a tourniquet just won't work well, those are really tough outside the OR. But across the board, that initial hemorrhage control is step 1.
Okay, the tough topic. Amputation. When does that become the primary consideration?
Well, the main goal is almost always to restore blood flow and save the limb, if doing so doesn't put the patient's life at unacceptable risk. So primary amputation, taking the limb off before trying repair, is actually pretty rare.
It's usually driven by.
Usually driven by the patient's overall instability, other life-threatening injuries, rather than just the difficulty of the vascular repair itself.
So amputations are more likely to happen after you've tried to salvage the limb.
Exactly, that's secondary amputation. In the upper extremity, the early limb loss rate is low, maybe around 2%. It's more likely after blunt trauma with multiple tissue injuries, or if the injury is high up or involves both forearm arteries.
And the lower leg.
The rate's a bit higher there, typically reported around 5%.
Wow.
Again, often driven by high-energy blunt trauma. And it's usually the severe damage to bone, nerves, soft tissue that tips the balance, not just the vessel injury.
Are there clear risk factors for leg amputation?
Yeah, we see some patterns. High-energy mechanism, older age, multiple arteries hit, really bad soft tissue damage, fractures, and compartment syndrome all increase the risk.
Any specific injuries that are particularly high risk for amputation?
Definitely. Injuries hitting both forearm arteries or multiple tibial arteries down low, and the popliteal artery injury behind the knee carries a high risk, maybe up to 30%, because it's the main pipe feeding everything below.
Right, a single inflow.
Exactly. And trying to reconstruct really small arteries distal to the popliteal is also high risk. The limb is often totally dependent on that fragile graft.
Saving the limb is one thing, but how well does it work long term? Quality of life.
Again, the long-term research is limited because follow-up is tough. But for the lower extremity, it seems like functional outcomes for amputees versus those with salvaged limbs can actually be pretty similar overall.
Really?
Yeah, though we need more data on graft durability and how that affects function over years. For the upper extremity, things like prolonged ischemia or nerve damage predict worse function even if the repair stays open. But data suggests we can usually save arms, and patients often prefer keeping even a partially functional arm over amputation.
That makes sense emotionally. What predicts worse function in salvaged lower limbs?
Advancing age, blunt trauma mechanism or associated damage, other injuries in the limb, and crucially, how long the limb was ischemic without blood flow.
So speed is key again.
Absolutely. Minimizing that ischemic time is critical for preserving nerve and muscle function. And we're really just starting to understand the broader social impacts, especially for older folks with other health issues. We need more data there.
Okay, let's shift to presentation and diagnosis. Speed and accuracy seem paramount.
Couldn't be more true. Quickly identifying and locating the injury is job one. The faster you restore good blood flow, the better the chance of saving the limb and function. How the patient looks when they arrive, their signs and symptoms guides everything initially.
We used to hear a lot about hard and soft signs, right?
We did. For decades, that was the framework. Hard signs, no pulse, active bleeding, a thrill or bruit. Expanding hematoma meant definite major injury needing surgery now.
And soft signs?
Things like diminished pulses, history of bleeding, nerve deficit, wound near a vessel they were suggestive, often leading to more tests like angiography.
But that's changed.
It's evolved. That system was developed mostly for penetrating trauma, pre-CTA era. It doesn't always capture blunt trauma well, and with CTA being so common now. While the rigid hard-soft distinction isn't as useful for guiding immediate decisions anymore.
So what's the thinking now? How do you categorize these presentations?
We tend to think more in terms of hemorrhagic, meaning active, significant bleeding, versus ischemic, meaning lack of blood flow downstream. Most limbs with suspected arterial injury fall into one of those categories.
Okay, tell me about the hemorrhagic signs. What are you looking for?
These are usually from penetrating trauma, tearing a vessel open. You see active bleeding, maybe signs of shock. The immediate need is hemorrhage control. That's the first step in vascular damage control.
We'll get to.
Right. Once you get temporary control, you figure out where the injury likely is. Sometimes the control measures limit imaging, but if the patient stabilizes quickly after resuscitation, a fast CTA can be invaluable for planning surgery. If not stable, straight to the OR.
And the ischemic signs. What points to lack of flow?
Ischemia is more common after blunt trauma that blocks or narrows an artery. You'll check distal pulses with Doppler, maybe measure the inner extremity index comparing blood pressures.
Mm-hmm.
These often come with fractures and soft tissue injuries that help localize the problem. Restoring flow quickly is still critical, but here, taking time for a pre-op CTA is often really beneficial because the repair can be complex.
And you need to know.
You absolutely need to know how long the limb has been ischemic. That guides decisions about maybe using a temporary shunt first or doing a prophylactic fasciotomy.
You've mentioned CTA quite a bit. It sounds like a game changer.
It really has been. It's the go-to now for diagnosing and locating arterial injuries, blunt or penetrating. It's fast, available, and most major trauma patients get a contrast CT anyway.
And it shows more than just the arteries.
Exactly. You see the bones, the soft tissue simultaneously. You see the vessels above and below the injury, which is crucial for planning. And with delayed scans, you can even get a look at major vein injuries. Its accuracy is incredibly high, close to 100%. It finds injuries even in tricky spots like the distal arm or below the knee.
Any downsides?
Yeah.
Limitation?
A couple. Sometimes contrast timing isn't perfect, leading to suboptimal filling. And metal fragments, like from gunshots, can create artifacts that obscure things.
Ah, okay.
In really heavy fragment cases, maybe conventional angiography is still better sometimes, but CT tech is improving artifact reduction all the time.
Okay, let's dive into the actual management principles.
Yeah.
Sounds like it needs to be coordinated.
Very much so. Vascular damage control is key, doing temporary things early before the definitive fix to improve survival and limb salvage chances in really severe cases.
What are those temporary measures for bleeding control?
Well, if they arrive with a tourniquet on, you might carefully loosen it for assessment if they're stable. You could also apply one in the ER. But sometimes they get in the way for surgery prep, so you might switch to manual pressure, then put on a sterile surgical tourniquet.
What about those tricky junctional spots, like the groin or armpit?
Yeah, direct manual pressure is often needed there until you can get surgical or endovascular control. A newer option is putting an endovascular balloon in the artery upstream, image-guided. Less invasive than a big open incision sometimes.
In Reboe.
Right. Resuscitative endovascular balloon occlusion of the aorta. That's for really unstable patients with massive lower extremity or pelvic bleeding. You put a balloon up into the aorta via the groin to stop flow to the lower body temporarily. Buys critical time.
Life-saving stuff.
Sure.
What about temporary shunts? You mentioned those.
Shunts are hugely valuable. Basically, sterile tubes put inside the injured artery to temporarily get blood flow going again distally.
Why would you do that?
It lets ortho fix fractures, gives time for resuscitation if the patient is really sick, or lets you transfer them safely if needed, all before the definitive vascular repair.
Used more in the leg.
Yeah, more common in the lower extremity and usually for injuries above the elbow or knee. A lot are put in just to bridge during resuscitation, often for less than 6 hours.
Any risks with shunts?
The main one is clotting off thrombosis, more likely the longer it's in and in smaller vessels. Anticoagulation helps, but isn't always safe in trauma. And rarely they can get dislodged, which is bad news. Need careful placement.
What kind of tubes do you use? Anything specific?
In a pinch, almost any sterile tube of the right size works, even feeding tubes. But ideally, you use commercial ones like the Argyle shunt, which is simpler plastic, or the Sun shunt, which is more flexible silicone with flared ends to help hold it.
Sun sounds maybe more secure.
Potentially. It sits differently and can be looped outside the skin, maybe less risk of dislodging or blocking small side branches compared to the Argyle.
So when do you strongly consider putting in a shunt?
Given how much ischemia time matters, you should think about it almost any time. Definitive repair might be delayed, long ortho case, resuscitation needed, transfer planned.
Makes sense.
And in really mangled limbs, maybe with both artery and vein injuries high up, you might even shunt the vein first, then the artery, to help drainage and reduce bleeding.
Okay, another term that comes up constantly. Fasciotomy. What is it? Why is it so important?
Fasciotomy tackles compartment syndrome. That's when swelling inside the muscle compartments gets so bad that pressure builds up, cuts off blood flow within the compartment, and damages muscles and nerves. It's a huge risk after arterial repair, especially if there was ischemia or bad ortho injuries.
So fasciotomy relieves that pressure.
Exactly. You make incisions through the fascia, the tough tissue holding the compartments, to let things swell outwards. Guidelines recommend it in high-risk cases, but it's still only done maybe 40% of the time with lower leg arterial repairs.
But the evidence supports doing it.
Increasingly, yes. Doing it early, with or soon after the arterial repair in the leg, seems linked to lower amputation rates and fewer
Although
complications.
it's most indicated.
More common in penetrating trauma, and especially with popliteal or femoral artery injuries in the leg. In the arm, it's usually brachial artery injuries above the elbow that cause compartment syndrome, maybe 20% of those cases. Multiple injuries or humerus fractures increase risk there too.
It sounds crucial, but are there downsides to fasciotomy itself?
Oh, yeah. It leaves big open wounds. Risk of infection, needing more surgeries for closure, longer hospital stays. Trying to loosely close the skin edges helps, or using special techniques like vessel loop ladders for gradual closure.
So when should you have a low threshold for doing it?
Pretty much anytime you restore flow to an ischemic limb, especially with multiple fractures or artery injuries, the longer the ischemia, the more likely it's needed. Also consider it for thigh upper arm with proximal injuries, especially if vein outflow is blocked and not fixed.
Is there ever a role for not operating? Non-operative management.
Sometimes, yes. With high-res CTA, we're finding more subtle injuries that might not need immediate intervention if there's no active bleeding and good distal flow.
Like what kind of injuries?
Small intimal tears or flaps in the artery lining contain pseudoaneurysms, maybe some small AV fistulas, but these need very close follow-up with repeat imaging, like CTA or ultrasound.
And if follow-up is iffy or things change?
Then you intervene early. You can't risk a delayed complication like a rupture or worsening ischemia if you can't watch them closely.
Endovascular therapy stents,
Yeah.
balloons. How does that fit into extremity trauma?
It's being used much more, especially over the last couple of decades, though initially more in the torso. In extremities, it's common for blunt leg injuries, and outcomes look similar or maybe even better than open repair, even in sicker patients.
Where does it offer the biggest advantage?
Often in those junctional areas, subclavian, axillary, iliac arteries, getting proximal control with a balloon can avoid huge open incisions.
And for the repair itself?
If you can get a wire across the injury, you can use balloon angioplasty, maybe stents for blockages. Stent grafts are great for sealing off bleeding or dealing with combined bleeding and blockage. And embolization blocking off vessels with coils or liquids works well for smaller vessel issues like pseudoaneurysms or AVFs in tibial or deep femoral branches.
Is it taking over from open surgery?
Its use is definitely growing. But we still need more long-term data, especially for off-label trauma uses. The initial less invasive benefit might not always beat potentially poorer long-term durability, especially in young patients.
So it depends on the vessel.
Yeah, outcomes are best in larger arteries. You need to be careful using stents in smaller ones, like the popliteal or brachial might need antiplatelets or anticoagulation. It's really a case-by-case decision, needing good communication between trauma and endovascular teams.
Which means open surgery is still very much the foundation.
Absolutely. Open control and repair is still the mainstay for most injuries. Ideally, you do it on a table that allows X-ray, prep the whole limb widely. If you need a vein graft, you prep that area too.
Traditionally, you take the vein from the other leg.
That was the dogma, yeah, to preserve drainage in the injured leg. But the data doesn't strongly back it up. Taking it from the injured leg is probably fine if there's no vein injury there and it's far from the artery injury site.
And the basic surgical principles.
Same as any vascular repair. Get control above and below the injury, then restore flow. But the bleeding often makes getting that initial control paramount and urgent. Longitudinal incisions give you flexibility to extend if needed.
Control can be tricky high up.
Yeah, might need incisions near the clavicle for the arm or into the retroperitoneum or groin for the leg. Endovascular balloons for proximal control can definitely reduce the surgical dissection needed. And if you can't use systemic heparin, you can use heparinized saline locally in the vessel.
Debridement, cleaning out bad tissue, is critical too.
Essential. Get rid of all contaminated, dead tissue. And crucially, assess if you have enough healthy tissue left to actually cover the repair. That's vital to prevent infection or breakdown. You might need to coordinate with plastics or ortho.
And you trim the vessel ends back to healthy tissue.
Always. Excise the damaged part until you see healthy artery wall. Check the bleeding from both ends if it's weak. Maybe use a Fogarty balloon catheter to gently pull out any clot. In really smashed limbs with bad venous outflow, back bleeding might be weak, even if the distal vessels are open. A temporary shunt can help confirm patency then.
And the goal is always repair if possible.
If the patient can tolerate it, yes. Urgent repair to restore flow is the aim. Acute ligation tying it off is rare. Usually a last resort in a dying patient, maybe planning for later bypass if they stabilize, but you have to watch like a hawk for ischemia after ligation.
What are the main open repair options?
Simplest is best. Small, clean tears might get a patch angioplasty with vein or synthetic material. Short, localized injuries in straight vessels might allow end-to-end anastomosis after mobilizing the ends, but zero tension is key.
And if those don't work?
Then it's an interposition graft bridging the gap. Saphenous vein graft from the patient is preferred. Short-term results are usually excellent, over 90% patency at 30 days. Early failures are often technical.
Why vein over prosthetic grafts in trauma?
Because trauma wounds are considered contaminated. Prosthetic graft infections are a nightmare, often need removal, can lead to amputation. They're especially risky if you don't have good soft tissue coverage. And long-term patency is likely worse than vein, especially in smaller vessels or below the knee.
So avoid prosthetics if possible.
Generally, yes, for definitive repair. Maybe a temporary prosthetic as damage control in a crashing patient, but not ideal long-term. Other conduits like bovine or bioengineered grafts have limited data in trauma.
Okay, let's quickly touch on specifics by location. Axillary artery up by the shoulder.
Yeah, pulse deficit isn't always obvious there. High suspicion needed with proximal arm injuries, especially with brachial plexus nerve damage. CTA or angio helps. Repair is usually primary or interposition graft, can't mobilize it much. Stent graft might be an option in stable patients.
Brachial artery in the upper arm.
Pulse deficit is common, often linked to humerus fractures or elbow dislocations. It's pretty straight, so maybe half can get end-to-end repair, others need a graft.
Forearm radial and ulnar arteries.
Pulse deficits again, often with soft tissue trauma. Need to do a Doppler Allen test to check the palmar arch connection.
What?
If one artery is out but the arch is complete via the other, you might just ligate the injured one. If the hand depends on the injured artery, you repair it. If both are injured, you try to fix the ulnar usually, as it's often dominant, often mobile enough for end-to-end.
Down to the leg femoral arteries in the thigh.
Distal pulse changes are common, can injure multiple femoral vessels. The profunda branch injury might not kill the pulse, but can cause a big thigh hematoma or hidden pseudoaneurysm, low threshold for CTA with penetrating groin trauma.
How do you fix them?
Common femoral usually needs a short graft or patch. Need to explore carefully all around it. Profunda can be ligated in unstable patients, but repair it if possible. It's important collateral flow. Profunda branches can often be embolized. SFA usually needs an interposition graft, sometimes end-to-end.
Popliteal artery behind the knee. The bad actor.
Often, yeah. Ischemia is almost always obvious. Ischemia time really predicts amputation. Strongly linked to knee dislocations, bad fractures nearby, and vein nerve injuries too. High amputation rates, 20–50%, lots of long-term problems.
Repair is tough.
Usually need a graft, often tunneled through the knee joint. Primary repair is rare. Medial approach, often separate incisions above below knee. Gotta try and save the little geniculate branches for collateral flow.
And finally, the tibial arteries in the lower leg.
Significant ischemia usually means a really bad injury disrupting all three vessels. Most repairs are for blunt trauma with multiple injuries. There's debate about just ligating one or two if the foot seems okay, but it's controversial.
Hard to know what caused the amputation if it happens.
Exactly, in those mangled limbs. But if multiple tibials are out, or just one is out but there is ischemia, you should try to fix at least one. Fasciotomy incisions can give access, usually bypass from the popliteal down. Need to think about geniculate supply and interval ischemia in salvage decisions.
L8 problems.
Isolated tibial injuries can be missed, leading to late pseudoaneurysms or AVFs, which can often be embolized.
Let's briefly cover the mangled extremity. Sounds awful.
It is. Severe trauma to everything: skin, muscle, nerve, bone, and artery, often with ischemia. Deciding primary amputation versus salvage is incredibly tough. No easy answer. The MSS score exists to help guide.
Mangled extremity severity score.
Right. Points for tissue injury type, ischemia, shock, age. Lower scores historically favored salvage, but with better techniques, maybe a higher cutoff is okay now. Bone and soft tissue loss weigh heavily. Importantly, MSS doesn't predict long-term function.
The function might be similar between amputation and salvage in the leg.
Seems that way sometimes, though selection bias is likely huge. Unclear if it's the same for arms. The key is a multidisciplinary consult, including vascular. If salvage is attempted, you need good tissue cover for the vascular repair. Generally, try salvage first unless the injury is massive or the patient too unstable. Life over limb, always.
One last specific frostbite. How does vascular injury play in?
Frostbite damages tissue directly by freezing, but also causes intense vasospasm. Then tiny clots form in small vessels during rewarming, often leads to digital amputation.
Can you treat those clots?
Not surgically in those tiny vessels, but catheter-directed thrombolysis clot busters dripped in via a catheter has been used as an adjunct. Data is mostly case series showing safety and maybe angiographic improvement. Mixed results on actually reducing amputation rates versus history. Seems better if done early and if angiography shows blockages.
So when would you consider it?
If there's persistent ischemia after rewarming, do an angiogram. If you see blockages, not just spasm, you might infuse TPA via a catheter placed proximally for up to 48 hours with repeat checks. Can treat multiple limbs, usually give heparin too.
Wow, we've covered a massive amount of ground. From the injury mechanisms to the complex decisions, what are the absolute key takeaways for our listeners?
I think first, just the sheer complexity. It's never just one thing. It's the artery, the bone, the nerve, the soft tissue, all interacting. Second, time is absolutely critical. Rapid diagnosis, rapid control, rapid reperfusion. And third, the limb salvage decision is incredibly nuanced, balancing the injury severity against the patient's overall state.
And was there a particular aha moment or insight for you during this?
For me, it's that shift in thinking from the old hard and soft signs to really focusing on the clinical picture. Is this primarily a hemorrhagic problem needing immediate bleed control or an ischemic problem needing reperfusion planning? It feels much more practical for guiding those first crucial steps.
Why is understanding all this relevant for someone who isn't a surgeon?
Well, I think appreciating the gravity of these injuries, but also the incredible advancements like endovascular options, shunting strategies, gives you insight into modern trauma care. It highlights the challenges, but also the progress in improving not just survival, but function too.
Okay, final provocative thought then. We've talked a lot about saving life and limb,
Yep.
but given the huge impact these injuries have, what's the next frontier? Where should research and practice focus beyond just survival and keeping the limb attached to really optimize long-term outcomes and quality of life for these patients?
That's the crucial question, isn't it?